My goal is to take care of our team so that we can take care of you in your practice consistently throughout many years, so that your products and your cases that go through us are always going to be the quality and basically the what you expect out of every case each time. So one aspect of it is surgery, where you may be hitting different anatomies that you shouldn't be hitting. The other part of it is restoration. That implant that was in the sinus, the patient will never see that. They'll probably feel discomfort and infections, but ultimately it's not right away noticeable. Delayed loading is kind of interesting because you've had a moment in time where people would just be doing guided or unguided surgery, take records, and then come back to do the prosthetic. What's interesting though, that has evolved a little bit today, where you do the surgery and then you take photogrammetry and then you can actually print the prosthetic yourself in your office, or you could have the lab make it and deliver it to you as soon as next day.
Welcome back to another episode of the Full Arch Advantage podcast. I'm your host, Gary Bird. I'm the founder of SMC National, where we help you create, convert, and close more full arch cases so you can grow the way that you want. And I am super stoked to have this conversation today with Armand, my friend from S3, who's the founder and CEO. I recently was in Hawaii and we did an event in Honolulu, and it was awesome. We had a bunch of doctors in the room, and I got the opportunity to actually watch his presentation. Now, normally, I don't watch all the clinical presentations because they scare me a little bit. I'm going to be honest with you. But I was in the room, I was watching it, and the stuff that he was sharing was so cool. And the questions and the engagement that he got, I just simply asked him, could you please come on today and give this presentation and just share what you shared with them? And he was gracious enough to say yes. Now, this is a long podcast, so this is longer than normal what we're going to do. So what we're going to do is we're going to break it into two parts. So make sure you stay tuned, buckle up. This is something that will look better on YouTube. If you watch it on YouTube, you're going to have more visuals, but you can listen to the audio and you'll get something out of it, but it will be better on YouTube. So I'm just going to warn you on that up front. Stay tuned.
Well, thanks for having me on here, guys. I'm going to show you what we often talk about, and that is full arch, obviously. But before we get into full arch, I want to make sure that the audience understands that there is a reason why we are where we are today with the technology. And it's important that we talk about the goals of S3 and what we do for doctors. And we spoke on some of this before, but I just kind of want to reiterate again a little bit. Number one, my goal with S3 when I work with you is that we want the best for your patients. This means that they deserve the best quality, not just a good enough quality, right? A lot of times when you work with companies or labs out there, what happens is you end up downgrading the treatment options when you work with the price point that's out there. And I'm going to talk about that a little bit later. And my goal for you is that your practice will grow, whether it be in full arch or single unit implants. I'm trying to simplify the process so that you can knock these cases out with efficiency, where you'd save time, costs, and avoid unknown costs. That's a big thing in dentistry is oftentimes you think you have one price, you come back and you realize, man, there's complications. And you end up costing more to the patient, more to yourself, more to your practice. And my third goal for S3 is to keep a consistent team. I take care of my team. This is really important, just like how you take care of your team in your office. My goal is to take care of our team so that we can take care of you in your practice consistently throughout many years, so that your products and your cases that go through us are always going to be the quality and basically the what you expect out of every case each time. All right. So that's kind of a quick brief synopsis of what I try to do with S3. Let's talk about the cases. Let's talk about dental implants. What you don't want to see ever in your implantology career are some of these pictures here. Okay. We're going to talk about what you're seeing on the screen right now. This is an X-ray of a couple of implants that have been mispositioned in the upper right quadrant. You can see one implant's upside down. How did that happen? You guys could probably guess, but it's probably pretty likely that the implants that were placed ended up in the sinus, and over time, they kind of migrated to wherever it wants, right? Not good.
Hey, got an important announcement for you. We are hosting the second annual Full Arch Advantage event where you learn to create, convert, and close more full arches so your office can grow the way that you want. This is going to be in partnership with BioHorizons, and this is our second year, but the important part is it's going to be virtual, so you don't have to fly out, buy hotels, travel with your team. You can just register and block off the days and watch virtually. And right now we have early bird pricing. It's never going to be cheaper than right now. I don't even have a discount code because it's so cheap. It's only $199 right now to register. And it's for your team. It's for your dentists. It's for your treatment coordinators, your dental assistants, and your marketing managers. And you're going to learn a ton of stuff to grow. Last year's event had a 74 NPS score, which is amazing. And the feedback was really, really good. So if you're looking at leveling up, we have a ton of new content, a ton of new automations and things that you can add to your practice to really grow, and executing on the phones to make sure that you can grow the way that you want. So don't miss this. Go to Full Arch Advantage right now and sign up. This price will not be around for long.
Next one, implants right through the nerves. Okay, this is unguided surgery. This is a multi-faceted injury, basically, if you want to look at it that way. Number one is you've got an implant going right through the nerve, and with the angle where that's going, that could be an unrestorable position for the implant. Here's another picture of something similar. I'm going to highlight here. This is the nerve canal. Here's the implant going in. And why am I showing you guys all this? It's important because we want to know why we do what we do, right? Like, why do you use surgical guides? I'm trying to convince you that you need surgical guides, whether it's a static surgical guide where we print something and you put it in a mouth, or you're using some sort of robotics. You need some sort of guidance in a patient's mouth, simply because we're not perfect beings. We can't deliver implants always perfect, always where it needs to be between the anatomy that it needs to be in, okay? So one aspect of it is surgery, where you may be hitting different anatomies that you shouldn't be hitting. The other part of it is restoration. This is what the patient sees. That implant that was in the sinus, the patient will never see that. They'll probably feel discomfort and infections, but ultimately, it's not right away noticeable. But restorations are, because when they brush their teeth, when they smile, when they take pictures, that's what they see, right? So without guiding implants, your restorative options become more difficult. So in this case, you see some resorption here going on where the metal aspects of the restoration is showing. And here on the bottom right picture, we're seeing that the implant is not parallel to the adjacent teeth. So restoration is going to be pretty challenging for that particular site. And you can see how there's even implant exposed above the bone on the x-rays here, okay? So I'm showing you all this not to scare you, but if we are in the business of minimizing risk, of increasing accuracy, of making sure that your patient walks away with what they need for the treatment, then certainly these screenshots are not something that you want to have happen to you or your patients, right? So again, restoratively, this is very challenging. How are you going to put a tooth on that? The angle of this abutment or the angle of this implant is so facial that it's going to be very difficult to create a crown that matches the contour of the adjacent teeth. And on the bottom right, you see angles of implants that are not parallel. So your occlusal forces is going one direction, while your implants are supporting the bridge going distally. All right, so let's talk about this one here. The bottom right shows a total of 8 implants, all right? 8 implants that we need to restore. Now, whether you're restoring that as sectional bridges, where you have maybe 2 or 3, maybe even 4 sections of bridges that you would restore to, it could also be a full arch case where you do a single roundhouse, molar to molar kind of restoration. The problem is, look at all those angles, okay? It's not only the restorative option, but it's also a cost option here that we need to talk about. Because when you have those kinds of angles, then you're going to have to deal with custom abutments, okay? Custom abutments are going to cost you much more than stock parts that you could purchase from the manufacturer. The pictures on the top left is another showcase of both surgical and restorative problems. These are implant positions where perhaps from a surgical standpoint, you open up the patient and you see, wow, there's a big ridge there. But then you put in the implant and you're going right through the buccal part of the bone. So now you have about 80% of the implant outside the anatomy. Okay. So I'm showing you guys, again, all these things is because I want to show you why we do what we do and how this applies to full arch. So a little bit of a study here. This is an older study. So everything that I'm showing here is probably about 12 years old. The technology has gotten a lot better since then. There's just not a lot of, I guess, universal studies on guided surgery. So I have to kind of pick and choose what's available out there, unfortunately. But this is probably the most objective data that we can get that I was able to find. Okay, this was a study done at a university. So they did a surgery on a cadaver where 33% of the surgeries that they did experienced buccal fenestration. That means the implant is coming through the buccal of the bone. Okay. Out of that 33%, almost all of them, 83.3% were free-handed and only 16.7% guided. And the way you look at that is there's a lot less error in the guided surgery portion of it, right? Makes sense. Now, notice that there's still 16.7%. So even if it's guided, you can still be a little bit off. And that's where I was saying earlier, technology's gotten a lot better. The scanning's gotten a lot better. The instrument's gotten a lot better. The fabrication of the guides have gotten a lot better. So I expect these numbers, if we were to do a similar study today, those numbers should be a lot smaller, even from 16.7%. Really quick here, going through these surgery data, and I like to show data because I'm not making this up, right? Angular data. So this means that how much deviation do you have between guided and freehand surgery? So the deviation, so the change from guided, the best error is 1.55 degrees. The worst error is 3.11 degrees. Okay, so you've got about a 1.6 degree difference between the two. Okay, not bad. Look at freehand. Over 3 degrees difference between the two. That means that your best target, your best guess, your best error margin is 3.31 degrees. Your worst error is 6.78 degrees. Okay, that's huge. That's the difference between putting in an implant and good bone outside the bone or hitting something else you're not supposed to. Okay. Depth deviation wasn't that bad. Truthfully, because once you start drilling, there's really one direction once you start going that direction. And even with freehand, you could position the implant where it needs to go, perhaps on the crest or whatever. And you could kind of gauge it pretty close. But again, it's still an improvement where your maximum error in guided is 0.93. Your maximum error on the freehand portion of it is 2.2 millimeters. Okay. So there's still improvement there. And then coronal position means that if you were to look at it straight on from an axial viewpoint, how much deviation can you go off? This one's a little bit deceiving because if you look at the C diagram here, your starting point when you start drilling is not going to be that far off because you know where you're going to drill. So that's where you're going to start, right? The problem is what's beneath that. Which angle are you going to go? Okay, so the lateral deviation is not that bad because you're looking at 0.85 millimeters when you're unguided. When you're not guided, you're looking at 1.43 millimeters off target. Okay, so between the two, you're looking at about a 0.6 millimeter difference. So not bad. Again, there's still improvement. Again, if we're dental professionals and you expect the lab to be as accurate as you do surgery, then you should be able to create environments where you're going to be the most successful. Okay, so that's why the guided surgery world comes in to help you. You want to minimize your risk and increase your success. That's why we do guided. And there's lots of different classification of guides. I like this one. This is from a good friend, Dr. Robert Stanley. So this is type 1 alignment visual aid. What this is basically just creating like a suck down with a hole through the tooth, and you kind of just eyeball where it goes and hope that the anatomy is there for you. Okay, that's a visual guide. And then it evolved to more guided surgery having pilot drill sleeves. This is a class 2, basically a 2 millimeter drill of some sort. And you simply just drill through that. And again, take the guide off, and then you got to freehand the rest. And then there are systems out there that are drilling only. This is what is called an osteotomy guide. We call that a type 3. And what that is you drill your width and depth drills, but you cannot put the implant through the guide. So if you have really aggressive threaded implants, those implants could still deviate from target. All right. And lastly, this is the most current up-to-date guided surgery. Type 4 is full guidance, which means that not only do you drill your depth and width drills or diameter drills, but you can also place the implant through the guide. The cool part here is that everything is planned for digitally. And obviously, if you follow the instructions and you follow the instruments, all your drilling and your implant placement should be very, very accurate. And that's what I was talking about earlier. The technology has gone a lot better, where this has improved more and more throughout the years. All right. So in full guided, just to review really quick, you got the angle guidance, you got the depth and diameter guidance, and you have the implant insertion guidance. And that's very important. And simulating that together with restoration and the digital planning is critical, because now you can combine all the accuracy and you can match that with your 3-unit bridge, like shown on this screen here. Obviously, now if you start thinking about, the gears thinking in your head, we can apply this to full large cases. All right. So now you can do this. You can idealize planned restoration, which is the left picture there. You can coordinate multiple implants planning. You can avoid critical anatomies. And now you can predict where the bone is versus where you think the bone is versus reality. And also, you can also synchronize that with the restoration. And these are some of the examples of what we do for our guides. And we make it out of really strong resin guided surgery material. I've been doing this for about 16 years, probably some of the strongest material I've come across in guided surgery. That's why it's got a bluish tint to it. It's a special material that I've really liked to use. And it's been very resistant to fractures and breakage and all that kind of stuff. So, all right. So we're here to talk about full arch. My passion, what I'm good at, is what I've been doing for 16 years. I want to show you what we can do for you with our guided surgery and full arch treatments to make it more efficient, more accurate, and repeatable in results case after case. Okay. So let's talk about what's available out there. Number one, conventional conversion. You guys know what this is. You have the freehand surgery. You've got a patient walking in with a denture that you convert. Typically, the study analysis and the surveys that I've talked to with different doctors, averaging between 6 to 8 hours total for that procedure. Okay. And then there's delayed loading. Now, delayed loading is kind of interesting because you've had a moment in time where people would just be doing guided or unguided surgery, take records, and then come back to do the prosthetic. So it's typically about a 2 to 3 hour surgery. And then you would deliver the prosthetic the next day or in a couple of days, whatever that may be. This is your typical next day teeth or teeth in 72 hours, that type of procedure. What's interesting, though, that has evolved a little bit today, where you do the surgery and then you take photogrammetry or digital scans, and then you can actually print the prosthetic yourself in your office, or you could have the lab make it and deliver it to you as soon as next day. So that's kind of evolved a little bit, and we can talk about that at a different time. And then, of course, there's guided immediate load. This is what a lot of people are doing today as a standard of care. Basically, what you're doing is you're doing guided surgery, and then you have a prefabricated prosthetic that you immediately load day of surgery. Okay. With most products out there, you're looking at about 3 to 4.5 hours. With S3, with our product, you could be looking at 1 to 3.5 hours. So we've improved upon that technique. So conventional conversion looks like this. It's been around since the 1990s. You do freehand implants, you open up holes in the denture, and you lute the denture to the chimneys, the coping cylinders, whatever each brand calls it. And it's a messy process. It's a long staking process. My issue with this is that the patient's walking away with what they had before. So unless you created a new setup for the patient, if the denture looked bad before, they're going to walk out with another denture that looks bad, or at least acceptable. But the only difference is that it's fixed to the implants, right? That's like the only difference. And it's, there are some situations today where that's effective. Lots of great doctors are using this technique, and that's fine. But there's technologies today that we have improved upon that I think we should take advantage of. The process is a little bit messy. You've got to have some sort of a makeshift lab in your office to create this kind of prosthetics. And this is an example that you could Google it. You could look up denture conversion process on Google, and you can find a bunch of pictures. So you can see how this is done. They walk away with something like this, gobs of material that's picked up in the prosthetic, and they walk away again with what they had before, except it's smoothed down and doesn't look much different. These things fracture a lot. I've seen a lot of these fracture because you're thinning out a lot of the material that you previously had. And also when you apply a burr to any material and that thing is grinding, you're introducing microfractures. You're basically preparing this case to be broken. So, and that's why, my thought is that we should do better than that, right? And then, of course, we have what is available today. Guided surgery where you have guides, you have prefabricated prosthetics. The common theme to all these brands and products is that they're all stacking. A fashion of it, a variation of it, whatever you want to call it, the principle behind it is that they're stacking. All right. This is something that I help create and help patent for my previous employer. So I know this system inside and out.
All right. So that's the end of the first episode, but the second episode is coming up really soon. Go check us out on YouTube and you'll see the second half of this, and you're going to want to see it because there's some major truth bombs in the second half that is going to bring this whole thing together for you. Stay tuned.